Hi once again. Continuing our discussion about stomach pathology, we will be knowing here about gastropathies, hypertrophic gastropathies, polyps and tumors associated with the stomach. Hypertrophic gastropathies are not a common disease to be seen. It is due to enlargement of the rugal fold. Why? Because it's because of hyperplasia of epithelium. Need to know but that there is no inflammation, there is only hyperplasia of the epithelium. It is mainly related to excessive growth factor release. There are two types of gastropathies mainly seen: Menetrier disease and Zoringer-Elson syndrome. Menetrier disease is a rare disorder. It is due to increased secretion of transforming growth factor alpha. There is diffuse hyperplasia of foveolar epithelium of body and fundus. Foveolar epithelium of body and fundus. And the main symptoms what you find is hypoproteinemia, weight loss, diarrhea. Secondary symptoms may be weight loss, diarrhea, and peripheral edema. Mainly, it appears with hypoproteinemia due to protein loss enteropathy. It may affect both children and adult. There is irregular enlargement grossly of rugal folds. Histologically, there is hyperplasia of foveolar mucosal cells. There is elongation with corkscrew-like appearance. Where else have you read about this corkscrew profile? Just remember where you had heard before. Okay, then since there is increased in transforming growth factor alpha, the treatment is to inhibit this. And since there is hypoproteinemia, you have to treat it with giving albumin, intravenous albumin. Okay, and coming over to Zollinger-Ellison syndrome, it is mainly seen in people more than 50 years of age. It is a gastrin secreting tumor, most commonly seen in fundus. There is increased parietal cell, doubling of oxytocin, the doubling of parietal cells thickness. It may lead up to 3 to 5 to 3 to 5 folds increase in number of parietal cells. There is hyperplasia of mucosal neck cells also because of this increased gastric acid secretion. The symptoms, clinical features are peptic ulcer diseases. There may be inflammation, ulceration, Barrett esophagus, and diarrhea. And the risk factors for this Zollinger-Ellison syndrome, keep in mind, is multiple endocrine neoplasia, MEN1. Okay, MEN1. An important thing in Meitner disease is it is associated with adenocarcinoma. Meitner disease is associated with the development of adenocarcinoma, whereas Zollinger-Ellison is not. And coming over to polyps of gastric stomach. Polyps are due to hyperplasia or due to inflammation or due to ectopics or due to neoplasia. Okay. Due to inflammatory and hyperplasia, about 75% of all polyps are due to this. This may be partly due to H. pylori infection. There is reactive hyperplasia and polyp formation. And fundic gland polyps, it is mainly associated with FAP, which you are learning in colon, familial adenomyosis polyposis. Adenomatous polyposis. Okay. And gastric adenomas are benign form of gastric adenocarcinomas. Adenomas are always occurs on a background of chronic gastritis. If there is chronic gastritis, they may lead to adenocarcinoma. Adenoma. Okay. Adenomas are composed of intestinal type of columnar epithelium. They exhibit a varying degree of dysplasia. High degree dysplasia is characterized by severe cytotoxic aplasia, irregular Okay. They are pre-malignant neoplastic lesions. These adenomas are pre-malignant neoplastic lesions. And then we move on to see, you may see the difference between all these. These two are hypertrophic gastropathies, and these 1, 2, 3 are polyps. These factors associated with carcinomas are in Meitner disease, in inflammatory and hyperplastic polyps, in fundus gland polyps and adenoma. Okay, and the symptoms varies. See, look at this. This, and this have the same complaints as that of chronic gastritis. Okay, and moving over to gastric carcinoma. Gastric carcinoma, most common malignancy of stomach. There are also other carcinomas like lymphoma. Okay, but main most common 90% of cancers is adenocarcinoma. Early symptoms, there may be dysplasia, dysphagia, and nausea. In advanced stages, like every other cancer, there is cachexia, weight loss, nodal enlargement, or complications like anemia and hemorrhage may be there. There may be paraneoplastic syndrome. You know what is paraneoplastic syndrome? The symptoms you see in the patient cannot be explained easily by the anatomical site of the cancer. Okay, acanthosis nigrans is a skin disorder, whereas the cancer is in stomach. You cannot easily explain the symptoms with of the patient. Okay, those are called as paraneoplastic syndromes. What are the etiologies of this cancer? At first and foremost, H. pylori infection. I have said in the earlier video to remember that H. pylori has an ability to conform nitrates to nitrites. Okay, nitrites. These nitrites are carcinogenic, so they favor formation of cancer. And also there is endogenous factors favoring nitrate converting bacteria like decreased gastric acidity or gastritis may favor the growth of this nitrate converting bacteria, and therefore they make it more favorable for the carcinoma to occur. Types of gastronoma, I will explain in late about pathogenesis of each type of gastrinomas. There are two types of gastrinomas. One is early gastric carcinoma and advanced gastric carcinoma. Early gastric carcinoma is a term where cancer is limited to mucosa and submucosa. You have 4 layers: mucosa, submucosa, muscularis and serosa. These type of cancers is related to only these upper 2 layers. Okay. There are 5 types of early gastric carcinomas, namely type 1, type 2, A and B, C, A, B, C and 3. Type 1 is also known as polypoid, 2A superficial elevated, 2B superficial flat, 2C superficial depressed and 3 ulcerated. Type 1, 2A, 1, 2A, 2B, 2C, 3. Polypoid, you see there is polyp, there is a tumor is like polyp. I have to notice that the tumor is only up to this yellow level, that is mucosa and submucosa. Okay. And type 2 is superficial elevated, superficial flat, superficial depressed and there is ulceration. Note that tumor is not extending below submucous, only ulcer is there. Histologically, these epithelial early gastric carcinomas histologically are well differentiated type. Okay, and care must be care must be taken to differentiate these EGCs from epithelial dysplasia and carcinoma in situ, because all three looks the same. And coming out to second type of carcinoma, gastric carcinoma, advanced gastric carcinoma. You have two types, diffuse and intestinal. Also they divide this into 5 types: ulcerative, fungative, sclerosis, colloidal, and ulcer cancers. At first we will know about this diffuse and intestinal type. Pathogenesis, I said no. Diffuse type, there is loss of E-cadherin. Remember, there is loss of E-cadherin. Okay, what is the pathogenesis? It is familial type of gastric cancer. So familially you have a loss of function of CDH1 gene. CDH1 gene is necessary for coding E-cadherin. E-cadherin is a cell adhesion protein. It's cell adhesive protein is E-cadherin. So in this diagram, E-cadherin is cell adhesive protein. It binds to beta-catenin. Okay, once there is wrong with E-cadherin, beta-catenin is able to move into nucleus. Okay, in the nucleus it activates the cell to proliferate. So the main thing here in diffuse type is there is loss of function of CDH1 gene, which is necessary for E-cadherin. There is loss of adhesion, and also important thing is E-cadherin is important for contact inhibition. You say like whenever there is a wound, the cells multiply. Why won't there be a cancer then? Because there is E-cadherin and it helps in contact inhibition. When two cells come in contact with each other, E-cadherin will bind to beta-catenin and therefore prevent beta-catenin to activate nucleus to further proliferate. And also there is mutation of P53. It is sporadic in nature, but familially CDH1 gene mutation. And second type is intestinal type. Intestinal, okay, the main difference between diffuse and intestinal is there is diffuse growth of the tumor in diffuse type. In intestinal type there is polyp formation, mainly they remain in cluster. It means there is no loss of E-cadherin. What is the causative agent then? What causes this ulcer? It's cancer. There is mutation in APC gene, adenomatous polyposis coli. Okay, adenomatous polyposis coli and beta-catenin itself. And there is increased WNT signaling pathway. WNT pathway stimulate beta-catenin. Also APC stimulate beta-catenin. This will form a transcription factor and helps in proliferation. There is uncontrolled growth. Okay, and this leads to carcinoma. Also the pathogenesis of carcinoma, not only these two, but there might be there might be the role of cytokines. Whenever there is increased pro-inflammatory cytokines like interleukin 1 beta, TNF, or decreased anti-inflammatory cytokines like interleukin 10 and interleukin 8, there is formation of cancer. So I want to explain all the before I said no, there are 5 other types of, you may divide advanced gastric carcinoma into 5 types: ulcerative, fungative, SCI, RAHOUS, scarus, colloidal, and ulcer cancer. Okay, I'll explain it now. Make 5 columns. Okay, 1, 2, 3, 4, 5. Everywhere stomach cancer only, no, so write stomach everywhere. Okay. The thing here is, in the ulcerative colitis, ulcerative carcinoma, this is fungative carcinoma, this serosal carcinoma, this is colloidal carcinoma, and this ulcer cancers. Okay. In the ulcerative carcinoma, there is cancer in the gastric canal. In the fungative, there is cancer in fundus. Serosal, also called as neoplastia, there is thickness of the wall. And in colloidal carcinoma, also called as mucoidal carcinoma, there is tumor in the cell wall. Okay. And in ulcerative cancers, there is something like tumor is there, it spreads everywhere, it causes ulcer everywhere. Okay. Histologically, how each of them look. You have ulcerative, fungative, serosal, colloidal, and ulcer cancer. Okay. Ulcerative colitis is poorly differentiated adenocarcinoma. So you have this normal mucosa and the glands. Okay, so ulcerative type, you have normal mucosa, but there is the glands have poorly differentiated cells. There is presence of hyperchromatism, like you see big nucleus there. Okay, this is ulcerative carcinoma, commonly seen in gastric cancer. This is intestinal type, gastric canal. It is intestinal type of carcinoma. And then you have fungative carcinoma. Fungative carcinoma, there is papillary pattern of the mucosa, and there is well differentiated adenocarcinoma. The other features of carcinoma, you see the nucleus is very big, you see nucleoli. Okay. And another type, third type is serosal, also called as Linitis plastica. Okay, here you have normal epithelium. Mainly the stomach looks like bottle, leather bottle. The wall is so thickened. There is no rugae. Rugae are predominant, but there is no ulcers. Okay. Histologically, it looks like normal mucosa is there, but you have signet rings. Signet rings where you have nucleus pushed to the periphery. Okay, these are the characteristics of Linitis plastica. The next type is colloidal. Colloidal, also called as mucoid. In this, grossly, as I said, in the stomach wall, mainly in the fundus, you see tumors. Gelatinous appearance is seen. Histologically, normal mucosa is there, but there is pools of mucin. Pools of mucin is seen. Pools of mucin is seen, and you may find signet cells. So this is the fourth type of carcinoma, and the fifth type and last type is ulcer cancer. There is tumor in the ulcer grossly, and histologically there is ulcer, and when there is ulcers there is inflammatory cells and there is adenoma. So these were the 5 types of gastric carcinomas. We now talk about where all this we will see the pictures first. Okay, this is intestinal type, elevated mass with heaved borders. I said no rolled out margins. Whereas in ulcers you have punched out margins. Here you have rolled out margins. Okay, and this is diffuse type. This is intestinal type. This is diffuse type. This is Linitis plastica. Okay. There is very thickened gastric wall. Histologically, this intestinal type, this is diffuse type. Gland forming cells infiltrated through desmoplastic stroma. What is desmoplastic is when there is these components of cancers, there is increased fibroblasts surrounding those, and this is signet cells. You can see these signet cells there. nucleus is pushed to periphery. Whenever you say cancer, it is characterized by having metastasis to other lymph nodes. So, which of lymph nodes? You know that it is supraclavicular lymph node, mainly left side. It may metastasize to those lymph node. And Sister Mary Joseph node, it is periumbilical lymph node. Irish node, it is left axillary lymph node. Krukkenberg tumor, you know, it's to ovary. Blemmer shelf, it's metastatized to pouch of Douglas. No, you have learned those in anatomy. And there is something called as carcinotumors. These carcinotumors are due to endocrine abnormalities. They are not actually carcinomas, they mimic carcinomas. Okay. Other types of carcinomas are leiomyosarcoma, lymphoma. Those are not much important. So at the end we have questions. Okay. It's good if I answer all these questions. Just pause the video and read these questions and answer. Know that if you can answer these questions. Okay. That's all. I hope this gastric pathology, the stomach pathology is completed. Not yet completed. We have this colon and small intestine to be done. We will be doing that. Okay. Till then, thank you.